Welcome to ICU Primary Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil, and I cannot hide my excitement today because it's our 100th episode.
Yay!
Well done, Maddie. And just wanted to say special thanks to all the listeners. I think because of you guys, we kept going. And even though we had so many different priorities in life, and sometimes we found it hard to be on time with our episode release, we finally got here. So thanks to everybody's appreciation, feedback, amazing listenership. So thank you, all the audience.
Yeah, thank you. And thanks, Swapnil, because this is your idea to create it. And I think when you asked me, I don't know how many years,
2018.
2018, then I thought honestly, I didn't think it would go anywhere or be like anyone would listen. So thanks everyone for listening. We really appreciate it.
There are a couple of things which came in last few months and a couple of emails that really touched. And I did share this with Maddie and Mike, but there was a candidate, George Lindley Jones, who sent a very touching email thanking to ICU Primary Prepcast team. And he mentioned quite elaborately about how this prepcast helped him to pass his exam in the first go. He did remember this podcast for a few specific reasons. Obviously, thanks to Maddie for her dad jokes at the end.
No, but I've become slack. I've become slack with them.
That's right. But also he made very precisely about Mike Clifford. Again, we can't thank enough to Mike for all the episode that he has done with us. And we are really sad that he's not doing any more episodes, but I'm trying to get him back again. Hopefully he will come back on board. But the amount of knowledge and amount of experience he brought into this podcast and all the episodes that he was part of were really, really well received by a lot of candidates. And even his sarcasm or sarcastic humor or much of humor that he brought to the podcast was well appreciated in George's email. So thanks, Mike, for all your support and being a fan, but also being the part of the team.
Yeah, thanks, Mike. Come back.
And also there was another email from another trainee in Sydney Kids. And these are the trainees none of us have ever met them in person, but obviously they send this quite touching emails. Another trainee from Sydney Kids, Charlene Butler, who sent another similar email thanking all the episodes, but also thanking specifically Mike because of his episode where we covered the neonatal physiology and the way he made it very simplified, even for pediatric trainee like Charlene, was quite amazing. And the listenership and the number of downloads that we get per episodes on Libsyn has been quite phenomenal. So obviously this podcast is breaking the records. Hopefully we'll keep going and hopefully we will have double century in us. We can't promise anything. That's what we'll try our best. So thanks again for all the love and support that you guys give us. So Maddie, let's dive into our business. So this is another interesting question that came in a recent exam and which was quite a struggle for a lot of candidates. So can you please describe the anatomy relevant to perform a lumbar puncture, to describe the adult anatomy or versus kids anatomy, because there will be slight differences?
So I focus on the adult anatomy because I'm an adult intensivist. Again, there's not a lot of resources that specifically focus on it. So it does require a bit of diving into various textbooks and online sites. And again, if you look at the show notes, I have included some extra information and also some diagrams, which I think are often more helpful to sort of get it into your head. And also for the exam, if you can remember a diagram that often a picture paints 1,000 words. So I just started with the location. So in terms of a lumbar puncture, as the name suggests, it's in the lumbar region. So there are 5 lumbar vertebrae, and these are the largest vertebrae in the spinal column. And they have shorter spinous processes compared to those of the thoracic vertebra, which do not extend inferior below the level of the vertebral bodies. And so this also helps make it easier to perform a lumbar puncture or any sort of puncture at this level. But the main reason we use this is that the spinal cord generally terminates at the L1, L2 level as the conus medullaris, which is attached to the coccyx by a thin cord called the filum terminale, which is a continuation of the pia mater, or one of the meningeal layers. And this stabilizes the end of the spinal cord. So distal to the conus medullaris, the nerve roots continue as a bundle called the cauda equina, which is basically because it looks like horsehair or the tail of the horse. And these nerve fibers, unlike the spinal cord, are loose and float freely in the CSF, making them less likely to be injured during any sort of puncture. And the lumbar puncture is traditionally performed at an L3, 4, L4, 5 level. In terms of the surface anatomy, when you're doing a lumbar puncture, so the spinous process of L4 lies along an imaginary line known as Tuffier's line, which connects the top of the posterior superior iliac crest. And even though we're traditionally taught that, you do need to be cautious because this line does tend to indicate a high level in obese patients and in the female population. And generally, we tend to use a midline approach, so below the spinous processes in the midline, but there are, especially in some anesthetic circles, they do use a paramedium approach. In terms of the layer that the needle passes through, so the first one is the skin and then the subcutaneous tissue, which is pretty self-explanatory. Following that, we get to the main ligament. So the first ligament you'll encounter is the supraspinous ligament. This is a strong cord that connects the spinous processes from C7 to the sacrum, although in a large proportion of adults, it ends at the L3, L4 level and merges with the thoracolumbar fascia. And it consists of 3 layers, which are the superficial, middle, and the deep layers. And basically, as you get deeper, less of the spinous processes are connected. So the superficial layer connects 3 to 4 spinous processes, the middle layer connects just 2 to 3, and the deep layer only connects adjacent spinous processes. And the deep layer consists of strong fibers of the aponeuroses of the longissimus thoracis muscle. After you pass through the supraspinous ligament, the interspinous ligament, and this connects the spinous processes from C1 to the sacrum. Anteriorly, it connects with the ligamentum flavum, and posteriorly, its fibers connect with the supraspinous ligament. And following this, you'll get to the ligamentum flavum. So these are paired ligaments which run between adjacent laminar vertebral bodies from C2-3 to the sacrum. They rise from the lower half of the anterior surface of the lamina above to the posterior surface and upper margin of the lamina below. And it's quite elastic, so it consists of 80% elastin fibers and 20% collagen fiber. And so this means it's quite flexible in nature. The thickness of this ligament increases as it moves down the spine, and it's thickest around the lumbar region, where it's about 3 to 5 millimeters. And the ligamentum flavum is a key part of the loss of resistance techniques that some people use when performing epidurals. So there's a sudden loss of resistance as the needle passes through the resistant ligamentum flavum into the epidural space. So that means next is the epidural space. So this is the area between the dura mater and the inner surface of the vertebral canal. And the space extends from the foramen magnum, and it's closed at this point where the spinal dura merges with the rim of the foramen magnum, to the sacral hiatus, where it is sealed by the posterior sacrococcygeal ligament. The epidural space contains numerous things, so fatty tissue, connective tissue, lymphatics, but the major thing from the clinical perspective is it contains blood vessels, and this is often the cause of a traumatic tap, so blood vessels that get ruptured during the needle passes through the epidural space. So the epidural space is divided into the anterior and posterior epidural space. So the anterior space contains ventral spinal nerves, basivertebral veins, and the internal vertebral venous plexus, whereas the posterior epidural space contains dorsal spinal nerves, intervertebral veins, and the sinovertebral nerves. After the epidural space, we get to the dura mater. So this is one of the big layers of the meninges. It's a fibrous, non-adherent layer which surrounds the spinal cord, attached to the foramen magnum and C2-3, and extends down to S2. Distal to S2, it merges with the periosteum to form a thin layer surrounding the filum terminale. And it's at this point that another pulp or sudden loss of resistance may be encountered as the needle passes from the dura to the subarachnoid space. Next to the dura mater is then the arachnoid mater, which lies beneath it, but it's not actually adherent to it. And this sends trabeculae across the subarachnoid space to the pia mater, but it's avascular in nature. And then we finally come to the subarachnoid space, and this is the area that we want to target for lumbar puncture. So this is a space between the arachnoid mater and the pia mater, which is filled with CSF, and it communicates with the intracranial subarachnoid space via the foramen magnum. So at the lumbar area, there is an enlargement of this subarachnoid space distal to the conus medullaris called the lumbar cistern, which contains CSF and the nerve roots of the cauda equina. So a lumbar puncture targets this area, this enlargement called the lumbar cistern. Anterior to this subarachnoid space, but where we don't really want to go, but it's where there's again, because if you imagine the cauda equina is encircled, so you again have the dura mater and the arachnoid mater encircle the cauda equina and the nerve roots. And then we get to the posterior longitudinal ligament. the vertebral bodies and the intervertebral disc, and then the anterior longitudinal ligament. So you can't really reach the anterior longitudinal ligament with your needle, but you can definitely reach the posterior longitudinal ligament and the vertebral bodies. And so it's just, you have to be mindful when you're performing a lumbar puncture. There are diagrams, as I said, in the show notes.
Thanks, Maddie. Just to highlight some of the differences between the adult and pediatric. Yes, if we are working in pediatric ICU, it might be useful, but also the next time the question might be asked between what are the differences between adult and pediatric population. So the key difference is really the where the spinal cord ends. It always ends lower in children, usually at or below the L3 level, versus in adult, it ends at L1, L2 level. So how does it matter to us, or what is the clinical implication? Obviously, you need to perform a lumbar puncture at a lower level, typically at L4, L5, or L5, even S1 level, to avoid the cord injury in pediatric population. Also, pediatric patients have usually thinner, less resistance ligaments, less subcutaneous tissue, and they have got a bit more flexible spine. Now, what is the clinical implication of not having more resistance ligament is you don't get that classic pop that we get while performing a lumbar puncture in adults. So that giveaway sensation when the needle pops through spine, we don't get that sensation. Usually, as the children grow from being newborns or infants, at the age of around 2, that's where the conus medullaris ascends to the adult level. So up till the age of 2, you need to perform the lumbar puncture at a lower level. And the anatomy or the understanding of relationship or the surface anatomy is quite important because adults have got larger amount of subcutaneous tissue compared to pediatric. Also, that means the needles that we are going to use in pediatric population have to be quite thinner and very smaller, and also lengthwise they don't need to be longer. In adults, the lumbar spaces or intervertebral spaces are quite well established, while in children, the intervertebral spaces are quite narrow. And that's why you need to do hip flexion so that you can open those spaces. So the positioning is going to be different in pediatric population compared to adult. So these are the kind of some differences that you need to think about or just to have in mind while you're performing the pediatric lumbar puncture. So Maddie, we are coming to the end of our podcast, and in our last episode I did promise the listener that we will go out with a bang.
I mean, I think that's promising a lot, but I thought it's been a while since I've asked you a question, so I thought, what's better than for our 100th episode, bring back some humor.
So basically you want me to get out on my century. Okay.
Yeah, that's it. Okay, so on the lumbar kind of theme, why does the vertebra enjoy horror movies?
Because it's sacral?
What? No. Because it loves the spine-tingling moments.
Oh my goodness. I wouldn't have got that in my next life.
Yeah.
Thanks, Maddie. So that's another interesting part of this whole journey that I always failed to Maddie's jokes. I never got a single joke right so far. So thanks, Maddie, for keeping me on toes. And we'll be back with a few more episodes. Till then, goodbye and have a nice time.
Thanks for listening and see you next time.